Good afternoon, good evening, wherever you are, and welcome to session 4 of the Oxygen and Critical Care series, the case-based series. Today we'll be discussing about escalation to a higher level of care when it comes to oxygen therapy. And our practice change objectives will involve we want to develop decision-making competence about when to admit patients to the hospital using the triage protocols and hospital admission criteria. And we should be able to define when we should say the COVID-19 is mild, moderate, severe, and when it is also it turns to be critical. Then we like to develop decision-making competence about how to design isolation areas for patients with suspected COVID-19. And we should be able to design or allow protocols for escalation of oxygen therapy. And we should be able to decide when a patient needs to be evaluated by a senior physician or a senior healthcare provider. We should also be able to decide when a patient needs to be evaluated by the ICU team, the intensive care unit team. If no ICU available, which we know most facilities don't have, we should be able to decide if and when a patient can be transferred to a higher level of care facility for continuous management. And we should be able to recognize how critical care can be provided outside of an ICU. We should know that it is not only in the intensive care unit that you can provide critical care. And we should be able to understand when to refer to a higher level of care within the context of what we have, the resources we have. We know we don't have the same resources, even within the same country. So we will look at the case here. This is the history of a patient who presents at the emergency department, or what we know accident and emergency units of our hospitals here. 36-year-old male presents to the emergency department with a 2-day history of fever, cough, and shortness of breath. He has difficulty in breathing. In the emergency department, the patient was screened for COVID-19 risk factors, isolated from the other patient, and is wearing a face covering. You know, we discussed all this in other series based on you have protocols which you can say these are the suspected patients and so on to triage them. Now you arrive, you happen to be the one on call, and you arrive to evaluate the patient and realize it is your colleague, meaning whether it's a doctor or a nurse and so on. So you are wearing PPE, that's personal protection equipment for contact, droplet, and airborne precautions. The patient admits he is short of breath, has a fever and a cough, but he denies loss of taste or smell, meaning he doesn't have these two symptoms, which also, are important in triaging. And the vitals that we're taking read a temperature 37 degrees Celsius, a blood pressure of 110 systolic, 74 millimeters of mercury diastolic, a heart rate of 94 per minute, respiratory rate was 18 per minute. And then his saturation using pulse oximetry was 92%. So you place him on oxygen therapy at 5 liters per minute by nasal prongs before continuing to obtain a history and performing a physical examination. You know you have to start something before you proceed. And in the past medical history, you found out that he was healthy but has had bronchitis in the past. And the past social history, he has past surgical history, rather. He had internal hernia repair in 1988. And he had no, he's not on any medications currently for any illness. And his family history revealed that the mother was deceased. She had history of hypertension and diabetes mellitus. The father is also deceased. He had a history of emphysema. He had a one younger sister who is healthy, and he had two children that are healthy. So in his social history, he works as a general practitioner physician. Remember, we say he's a colleague. He doesn't smoke, does not use any controlled drugs or illicit drugs, and does not consume alcohol. And review of the system review, there was nothing remarkable. So physical examination revealed is the neuro is alert, and the A and O you see there is alert and orientated. And he has what is it, PEERL? I can't recall the, but it's pupils are equally reactive to light, so they're normal. And it moves all extremities, and there is no focal deficit. Airway has Mallampati 2. This is what we do in anesthesia. You assess the airway. And he has mouth opening that's oropharyngeal. The mouth opening is greater than 3 centimeters. Dentition was intact. Thyromental distance greater than 6 centimeters. In the cardiovascular system, he has a regular rate rhythm, the pulse. And there are no, the heart sounds reveal no murmur, and there is no rubs or gallop rhythm. Capillary refill is normal, it's less than 2 seconds. And the chest, he has a coarse press sounds anteriorly, and is tachypnic at that time, 32 beats per minute. That's 32 breaths per minute, rather, sorry. And abdomen is soft, non-tender, and non-distended. There is a bowel sounds were hard. And there is edema, bilaterally at the extremities. The skin was warm, dry, and intact. So with all these features and the history and the features, would you admit this patient to the hospital? Or would you rather manage this patient at home? You send him home with medication and say you should manage at home, just like what we used to have these days for COVID-19 home-based care. And does he have mild, moderate, or severe disease? Maybe we'll give you just some seconds, some 30 seconds to type in your answer whether he has mild, moderate, or severe disease. And then before we move in to see the material that can guide us in this. So answer, type into the chat box. So Irene, I would like you, if you are with us and okay, I would like you to take this part because I know you have a very good experience at Irua, where you have good center for managing COVID-19 patients. Okay, all right, let's see the chat box. Okay, so it says severe COVID-19. Okay, so let's click and see what material we have to learn. Say patient needs to be admitted. Yes. So when you click on that, you will see the material that can assist us. You have the clinical spectrum of SARS-CoV-2 infection, that's COVID-19. And you will see that there are about 3 or 4 categories. In general, adults with SARS-CoV-2 infection can be grouped into the following. You can have the following severity of illness. You can have the asymptomatic or pre-symptomatic individuals who will test positive for the virus, and but they don't have overt symptoms. Then you have those with a mild illness who will have the fever, sore throat, malaise, feeling of not being well, headache, muscle pain, nausea, vomiting, diarrhea, loss of taste and smell. But they have no shortness of breath, dyspnea, or abnormal chest imaging when they have a chest X-ray. Then the moderate illness group will have all the above, and then their saturation, oxygen saturation, will be about 94% on room air. Then the severe illness, this will be individuals with saturation that is less than 94% on room air at sea level. Remember, we say at sea level. And when you do their special oxygen concentration, when you do a blood gas analysis, you have the ratio of PaO2 to FiO2 of less than 300 millimeters of mercury. Okay, so this will be the guide. So looking at this now, will you now say this patient will now have what? It falls into moderate illness, right? So this is what you can use to guide for such kind of patient. Let's get back to the main case. Okay.
Hello, Dr. Datti.
Yes. Yeah, I wanted you to say something about this.
I was muted rather.
Oh, sorry about that. So I wanted you to get in knowing your experience.
There were some
Yeah. Go ahead.
Yes, I said there were quite good responses in the chat box.
Yes. Okay.
Hello.
Yeah, I can hear you.
I said we got quite a number of responses in the chat.
Okay.
Okay. I said we got quite a number of responses in the chat box. So we had a lot of people, all agreed patient needed admission, which is quite good because patient had symptoms and also now had a saturation of 92%. So, and we had a number who said moderate, some said severe disease. But I think you've actually gone through that as regards based on the criteria where they will fall into, where this they will fall into.
Yeah. Yeah, that's correct. And the other thing they should look at as a guide, because remember this patient was commenced on oxygen therapy before you even continue to get the history and continue with the examination. So that signifies this patient needs to be admitted at least. So, so the practice. Can we scroll? Yeah, okay. So you need in your facilities to develop a triage protocols and admission criteria if you don't have one, or if you have one, you need to review them to suit your own triage and admit patients with suspected SARS-CoV-2 infection, that's COVID-19. Then you need to educate all providers regularly regarding the definition of mild, moderate, severe, and critical illness with COVID-19. The material we saw a moment ago, you can use it to write I mean, paste it on where you practice to remind you, these are the symptoms for mild disease, this is for moderate, and this is for severe. That will help you in taking decision. Now, we ask you, Irene, you want to take the next, this? Hoping that you remember what is AIIR. Okay, okay. Can you hear me, Irene?
I think Dr. Irene is muted.
Okay,
Maybe
so Dr. Salim, can you come in now?
Okay.
Yes, it's Dr. Salim. You can take on, Dr. Salim, you are muted.
Okay, I'm unmuted now.
Okay, you can go ahead from this part. What is an AIIR? Let's see the response.
Okay, the AIR stands for Airborne Infection Isolation Room. It's a kind of negative pressure room that uses lower air pressure to allow outside air into a segregated environment, that is into the isolation room. But this, it traps and keeps potentially harmful particles, that's infectious particles, within the negative pressure room. So it's a kind of protection to the healthcare workers in the sense that outside air does not get into the isolation room. By that, isolation, infectious particles within the isolation room where the patient is cannot get outside to infect the healthcare workers.
Yeah, that's correct. So you have this question here.
Okay.
Do we have AIIRs? Do we have this kind of facilities in our hospital? Or and then what other, if we don't, what other option do we have to isolate patients and keep both providers and patients safe, like you said? So maybe participants should type what they have in their facilities before and see what we have.
Okay.
We give them 40 seconds.
All right.
Okay. You can type into the chat box. Have an AIIR, but what other options do you have to keep the workers and the patients safe? Based on the experience, you know, we had the second wave of COVID-19 also.
No response yet.
No response. So it's so you can continue, Dr. Salim.
Okay.
If we
Well,
click,
it is
educate.
very obvious that most facilities are without the negative pressure isolation rooms. So, but there are other methods of using ventilation to reduce the aerosol burden from infected patients. And some of these methods, they rely on ventilation. When we say ventilation, the movement of air in a building and replacement of inside air with air from the outside. So generally, there are two types of ventilation. We have the manual, natural ventilation, and then mechanical ventilation. The natural ventilation, it relies on open doors and windows to bring air from the outside to the inside of the room. Well, the mechanical ventilation, from the name, it usually refers to the use of mechanical air moving equipment that circulates air in a building and may also involve heating or cooling. So based on this, ventilation can reduce the risk of infection through dilution and removal. because by the time you allow outside air into the room, you are diluting the air within the room. So thereby reducing, diluting the concentration of infectious particles, and then thereby also reducing the risk of infection. So, and this is a similar mechanism that happens when we open, by opening doors to dilute an objectionable odor. So dilution reduces the likelihood of that person in the room will breathe air that may contain infectious particles. So this removal, this is just one way, the natural way, by opening windows and then and doors. Then another way to achieve that is the use of fans, propelling fans, either a ceiling fan, a standing fan, or a wall fan. Then other things include the use of hello?
Yeah, we can hear you.
Okay, so other mechanism is the use of standalone filtration units, and then ultraviolet lights that will trap and kill the infectious particles. So these are some of the ways that where in places that doesn't have the AIR can reduce the burden of infection.
Yeah, indeed. Thank you very much, Salim. And remember, the PPEs become handy here, whatever you have. Irene, I'm sure at Irua you have an experience to share with us on this.
Okay, thank you, Dr. Datti. Of course, we don't have the EIR. Those things are quite expensive. I think the natural methods of those cooking, particularly in those days where COVID patients are isolated, open windows, ventilate, and the use of fans. And in one or two rooms, we have the exhaust fan. So I think we all can still achieve in our own centers. And for COVID and for areas where we need to reduce airborne infection. So that's why we use fans, and we have a lot of open windows. The isolation, the COVID isolation unit, it has a lot of windows, you have more windows than walls. So you are able to have the natural ventilation. But then, of course, staff coming in have to use PPE.
Okay, thank you very much. So the practice change action items here, what is needed for all of us, depending on what we have, is to put isolation protocols in place if you don't have one. If you have one, you keep reviewing it so that you can achieve the desired goal. Then you should know where the patient isolation areas are within your facility. And you should understand how physical distance and ventilation can protect patients and healthcare providers when AIR are unavailable. So this part is very important when you don't have this kind of room. Then that is when we must emphasize on the physical distancing. And you must use the PPE, the gloves, the mask, N95, and so on to protect yourself and protect the patient. Then you must ensure the education of all other healthcare providers, including cleaners, on all these protocols. All right. So in addition to ordering a nasopharyngeal, we are continuing with our case. In addition to ordering a nasopharyngeal swab for SARS-CoV-2, what additional diagnostic investigation will you order? So apart from, we all know that to do the test, we take a nasopharyngeal swab to test for COVID-19. So what additional diagnostic will you order for this patient? Type in the chat box. Okay, I've seen somebody say chest X-ray. type your answers into the chat box. Remember, it's a discussion. Chest X-ray, yes. Thank you, Dr. Umar Adamu. Chest X-ray, excellent. So, yes, the full block count, yes, is okay. Chest X-ray. Chest X-ray. Okay, excellent. So we need a chest X-ray to be able to define the severity to categorize this patient. So we can scroll down a bit. As I say, chest CT, yes. So this is a chest radiograph of the patient. Okay, let's scroll down. So you need to see the changes. Okay, is there any change here in this, any feature on the chest X-ray here? Suggest something? Okay, let's scroll down. Okay, so this is the update now on the patient. Dr. Suleiman, if you are good with your audio, can you take this part? Oh, I think you are muted. Dr. Suleiman, you are muted. You have to unmute.
I wonder if Dr. Suleiman, maybe you can send a message through the chat if you can't unmute yourself.
Hello? Dr. Suleiman, you are muted. You have to unmute. Okay, maybe I should just continue. When he's able to, I can't get response from Suleiman. So if you can hear me, the patient is admitted. Like you all said that, yes, this patient needs to be admitted. Now, finally, the patient is admitted to the hospital and transferred to an isolation bed on the hospital ward. He remains on 5 liters per minute of oxygen via nasal cannula. When he arrives to the ward, the nurse obtains a new set of vital signs, different from the ones that were recorded on presentation. And the heart rate now is 99 beats per minute. Blood pressure, not still almost the same, 103/60 millimeters of mercury. Respiratory rate now is 28 beats per minute, up from 18. And then saturation now is 89% on 5 liters per minute via nasal prong. Supplemental oxygen is saturating 89%. Temperature now is 38.5 degrees Celsius. Okay, so the question now is, when should oxygen therapy be escalated? Let's post in some answers in the chat box. Let's see, all following this discussion. When should we escalate? When should we increase the oxygen therapy. It's clear now at 5 liters per minute using that device, we are not achieving a good result. We're getting 89, less than 90%. So type into the box. Yeah, you said now. Yes. Somebody said now. We should escalate, but okay. Any other person? Answers? As soon as possible, escalate now, immediately. Okay, excellent answers. So let's click and see the way that can help us. Yeah. So when you click on that, you on the Learning Resource Center, you will see guidelines on how to use oxygen. It's a 20-page material where you have the guideline to guide you on how to use oxygen in adult, acute oxygen use in adults. Okay, it's a Thoracic Society of Australia and New Zealand. So you will find all you here to help you with that. So let's go back. Okay, so now below is one example of an oxygen device escalation plan. How would you develop an oxygen escalation protocol for your facility? Suleiman, if you are still with us now, are you with us now?
Yes, I am. Sorry, I lost my.
It's okay. So if you are following, we are here now to devise a plan on how to do. We all agree that this patient therapy, oxygen therapy, needs to be escalated. It's clear that the 5 liters per minute of oxygen the patient is getting is not yielding the desired result. We're getting 89%, and then it's more can keep now 28 per minute. Now they will all agree to escalate. Now here is example of escalation.
Sorry, Dr. Datti. I would just like to ask the participants to mute themselves. Okay. Participants who are now joining, please make sure that you are muted.
Kindly mute your mics, please.
All right.
Okay, Dr. Suleiman. So that's the plan. We can take them on that. Let's see what.
Okay, sir. Thank you very much for that. We are talking about escalation of oxygen therapy, and which may mean, changing from the initial device that we're using to another device which may deliver more oxygen in terms of both flow and concentration. So that's what will inform the choice of the device that we are going to please go back to the poser, the question. Okay, so they said, it says below is an example of an oxygen device escalation plan. How will you develop an oxygen escalation protocol for your facility? But rather, I think before we move into develop an oxygen protocol for our facility, let's look at this particular patient who has been on nasal cannula at 4 liters per minute. Now, the question I'm going to that among all these devices, we have 1, 2, 3, 4, 5, 6. Number 1, which is the nasal cannula. So if we are going to escalate, saturation is 89%, he's tachypnic now. Which one do you think is the most appropriate to use here? I would have loved if they are not numbered, and probably he wouldn't have given any clue. But I still want to hear from the participants, how do they want to, move from which one and why? So the floor is open for us to, type in our answers and see how the discussion goes from there.
You can type in the number of the device you see on your screen. Okay. So the current Venturi, cannot the Venturi mask.
Okay.
Say two is Venturi mask.
Venturi mask.
Somebody said number 6, intubation. Someone said 2, 5, 6, and then someone says 1 to 6. Interesting answers.
Yeah.
To ventilator.
Escalate to ventilator.
I think we've got enough responses.
Yes.
To.
Yes. So I think the participants have responded, and we're going to look supposed to be applied and when it's supposed to be brought to use. And I think that's what this information, what we're about to click will tell us. It will give us information on the various to give us information on the various equipments, the advantages, the pros and cons, and when they need to be used. So let's move down. Let's move down. Okay. Let's move. Move to know where each individual equipment is being discussed. We have discussed all this. This is pertaining the tests. Yes, no, not cardiovascular. Yes, that's the non-invasive respiratory support. Okay, so this is a diagram, showing how one is supposed to move. Okay.
67.
Please, I think the participants should mute themselves. We are getting some background noise, which will definitely affect us. Hello. Dr. Datti, can I continue?
Yes, you can continue.
Let's add them to.
Participant named Levy, I think you should mute yourself. Levy Korheina, you could.
Yeah.
Okay. Please mute your mic. Levi, can you mute your mic, please?
Yeah, but I think my mic is muted.
It's not. And that's why we can hear you. Sorry.
All right. Thank you very much for that. So, always we start with low flow oxygen therapy. This is important so that we manage our resources adequately. But of course, it depends on the severity with which the patient presents with. Of course, if a patient is presenting with very severe disease, of course, you may want to start at mid-level or at the higher level. However, for this particular patient of ours, the disease, his presentation was initially moderate. However, now it's becoming severe, and that's why there is need for us to escalate oxygen therapy. And as you can see here, always you move from a low flow nasal cannula, which is usually the initial therapy, to a high flow nasal cannula. This help in increasing the flow and therefore increasing oxygen that's available to the body. Also, the FiO2 may need to be increased depending on which equipment you're using. Most of our initial equipment usually give 100% oxygen, and if you are using an oxygen concentrator, we know that it gives as high as 95 to 98%. And when you are using this and it's not working, then that's the time that you should escalate to a non-invasive, ventilatory therapy, which include the CPAP and BiPAP. From the non-invasive, you now move to invasive therapy, which is the use of intubation and mechanical ventilation. So also here, there are some things that you can use which will serve as adjunct to the oxygen therapy, such as positioning. The prone position has been shown to reduce incidence of atelectasis, help in recruiting more lungs, and also reduce severe hypoxemia. Other things that can be employed if you have the facility available is venous ECMO, which is extracorporeal membrane oxygenation, which is usually the last resort after you have used low flow, high flow oxygen administration devices. You have moved to non-invasive therapy. You have moved to mechanical ventilation. You have used prone positioning. If all of this fail to provide adequate oxygenation, then you move to ECMO. Let's move down. So at least this has given us an idea of how we are supposed to move in terms of escalating oxygen therapy. Okay, so they said the general principle is that in COVID-19, the main cause of hypoxemia is atelectasis, which is lung collapse. So all what we are trying to do is try to see how we can recruit, first of all, prevent our alveoli, the patient's alveoli from collapsing, and then secondly, to try to recruit those that have collapsed. Okay, so the recruitment measures are prone position, as we've mentioned, and then also the positive airway pressure, that's the CPAP and the BPAP. Okay, so let's move down. So there is an interesting aspect to this proning position, because as we know, COVID can as well affect pregnant women. So in pregnant women, of course, we know putting them in the scenario which is presented to you, you may be able to, involve full proning, but of course, it's not all patients that are comfortable sleeping in this position. So for those that are unable to do that, that's a good sign that you may use CPAP or BPAP, at night while they are in supine position. And okay, so, and at the same time, patient can be alternating between the prone and the side or supine position, depending on how it works for you and your clinical judgment. So the high flow nasal cannula, the advantages is that it precisely titrates, it's a precisely titrated oxygen support, and it comes, some form of humidification, and of course, we all know the advantage of having inhaling a humidified air. And then it also has a low level of PEEP. And we know for patients with atelectasis, okay, for high PEEP can compromise, can lead to cardiovascular problems. So in patients that are having respiratory failure, you may want to, reduce, in as much as PEEP helps to recruit more lungs, you should as well, try to titrate it so that it doesn't lead to cardiovascular compromise. Okay, so so they are saying that the high flow nasal cannula on itself, okay, do not promote recruitment. So this may be inadequate to break the vicious spiral of recruitment. So whenever possible, this high frequency nasal cannula should be combined with positioning, which is proning. Okay, so the next one is, if you have tried this and still it's not working, the next one is CPAP or BPAP. As we all know, this is a positive pressure mode of ventilation. It can be given both invasively and non-invasively, but here we are talking about the non-invasive one first, okay? So patient with morbid obesity, sleep apnea, obesity, hypoventilation syndrome, and COPD, benefit from this form of oxygen therapy the most. So assuming this our patient falls into one of these categories, of course, if we're escalating, I think to escalate to this form of oxygen therapy, it is available to us, okay? So also patients that are unable to tolerate awake proning, which we have mentioned earlier on, may benefit from this. So I said mostly is applied at night. Usually during daytime, monitoring is more adequate. So at night, you don't want to take any chances. Staffs may fall asleep and something may happen, and before you recognize, it may be too late. So it's safer whenever possible, during the night period, to place patients on this CPAP so that oxygen therapy can be guaranteed throughout the night, and it allow patients to sleep comfortably. So okay, that some patients may actually have some hemodynamic issues and may require to be stabilized. Okay, so that's that. And
so I think Dr. Suleiman,
yes,
because of the other areas we need to cover.
Time. Okay.
Yeah, I think it's clear. Maybe let's go back to see what follows there, because there's something I want to say.
Okay.
Let's scroll down. Okay.
Okay.
Practice change actions from this part of the therapy is that we should decide when oxygen therapy is inadequate, which we did from this discussion. We all agreed that the 5 liters nasal cannula is not enough based on the vitals we've seen. And then we should know the goal of the SpO2, that is saturation. For pregnant patients requiring oxygen, we should also know the goal of SpO2 for COVID patients requiring oxygen, and take inventory of the types of oxygen delivery devices available in your facility. Now, this is very, very important. I was going to say that. And should decide when oxygen therapy should be escalated. Now, talking about this, the inventory of the types of oxygen delivery devices, we should know the resources we have. Now, you assess what you have, like you want to escalate now and you don't have the facilities to render the high flow nasal cannula therapy, or you don't have facilities to intubate and ventilate, then you know you need to transfer this patient out of your facility to another facility that has these resources. So this is important. But when you have it, then from that unit, whether it's in the emergency, you want to now transfer this patient to a high dependency unit or an ICU. Where you don't have those ones, then you need to transfer to a higher facility. That is the whole, that is the practice change you should also have to take note of. Thank you very much, Dr. Suleiman. Now, at what level of oxygen therapy should a senior doctor be called?
Hello, sir.
Yes, Dr. Suleiman.
Yes, sir. Before we move there, I want to quickly draw our attention to this very point of goal of SpO2 in pregnant patients, which we should know that we tend to have less threshold for them to become hypoxic due to the fact that the baby too may suffer. So usually we tend to have less threshold for escalating oxygen therapy in this particular group of patients. So that's important to note when you are dealing with a pregnant patient. You don't wait until she's 90% or 89 or 92 before. Once it's less than 95, you should think of escalation. Thank you very much.
Yeah, thank you very much for that reminder. So if Dr. Salim is okay with his audio,
yes.
Take us this next step and see what we have. At what level of oxygen therapy should a senior doctor be called?
Okay.
So we want them to type into the chat box.
Yes, let the participant types in the chat box so that from there we can take on the discussion. Assuming you are with this patient, at what level will you consider calling a senior?
Okay, someone said SpO2 less than 90% from Joseph. Thank you. When we are escalating, we should call the senior doctor, okay? Keep them coming. Remember, it's a discussion, when SpO2 is less than 80%. Okay. When you think there is need to escalate, so at the beginning you should call the senior doctor. Okay. Oh, Dr. Salim, I think we have some responses.
Okay. All right. Thank you. Once a patient requires a max instead of a nasal cannula, then at that point, one should consider calling a senior person, because escalation of oxygen therapy, it largely depends on the available resources. So it's good that we have to have an inventory of the oxygen delivery devices so that we can know how we can, whether we can improve the patient's care. Because by the time from the available resources, you cannot improve on the oxygen therapy, then it means the patient needs a higher level of care. At that point, one should consider referring the patient. And for that to be effected, then there is a need for a review by the senior. So any patient that requires a face mask instead of the nasal cannula to attain the SpO2 goal, then a senior should be called, a senior doctor should be notified. So let's click on the, let's click so that we get more information
on
on that.
page, you had each of them.
Okay.
And this is 510 liters per minute. You know, you had those values in that other one. Yes.
Sorry.
And
We
check
are having a background interference. Okay. So our key recommendations from this American Society of Thoracic Surgeons, there are key recommendations they give on when to call a senior doctor. And then for any patient, the recommendation says for any patient who needs an FiO2 of greater than 4.0, as mean, for example, a patient that requires a flow rate of more than 6 liters per minute via a simple face mask to maintain an adequate SpO2, then should receive a senior clinician review. That is one. And then secondly, if the FiO2 greater than 0.5, that's such as greater flow rate of greater than 8 liters per minute via a simple face mask to maintain adequate saturation, such a patient should be referred to for an ICU review. So once a patient requires greater than a flow rate of greater than 8 liters per minute, the ICU team should be notified. And if it happens in a facility where there is no ICU or ICU teams, then such a patient should be considered for a higher level of care. Higher level of care, that is, such a patient requires increased monitoring. So such a patient should be referred to a ward where you have higher nurses per patient ratios, or the patient can be transferred to another facility. So these are the situations where you can call for a senior doctor review. Thank you.
Yeah, thank you very much. The emphasis here is that, like you said, Dr. Salim, that we need to assess the facilities we have in terms of oxygen therapy, the devices. Then, of course, calling a senior doctor, if you have one, you know, he has the experience and has more knowledge and will come in to guide. The moment you need a higher FiO2. FiO2 means fractional inspired oxygen concentration, which is the same if you say FiO2 upon 5 means oxygen, percentage of oxygen is 50%. So once that is the cutoff or the landmark, once you are giving more than FI 2/4, then you know that you need a senior doctor, because you know that part of the one way to escalate the therapy, like the participant also said, intubation, that's invasive oxygen therapy, which comes with its own other demands and complications, because it has to be done in an ICU setting. And we know that many of our facilities don't have ICU or HDU. And where we have some, we don't have, this month we will have the resources. The following month, they are not coming. We've used up all the consumables. So it's relative. We can be poor resource periodically. So it's important to understand this and know when to transfer this patient out of the facility to another facility. Thank you very much. Can we scroll down, please? Okay. Okay. This is the the role of away from position has been explained by Dr. Suleiman earlier on. So we go to the case update. Now, the patient has been re-examined again to assess the response to the intervention so far. And he was found to be alert and orientated, and the pupils are equally reactive to light, and then moves all extremities, no focal lesion, airway, I think Malampati 2, and then mouth opening is greater than 3 centimeters, it still remains the same. Now, the only significant finding here, the coarse breath sounds, the chest, and then his tachypneic rate at 32 per minute. Abdomen is still the same, non-tender, non-distended, and the bowel sounds. There is edema in the bilaterally at the extremities. The skin is warm, dry, and intact. So the question here is that, is this patient in respiratory failure? How is respiratory failure defined? So let's click and see what we have here. Okay, so in defining respiratory failure, you have, it can be acute. In this case, it can be acute in this patient. And the objectives here is that you should be able to recognize the clinical signs and symptoms, and then you should be able to define and classify the acute respiratory failure. Describe the various etiologies of acute respiratory failure, describe the pathophysiology of hypoxemic respiratory failure, and so on. So in acute respiratory failure, the definition here is that when there is a loss of ability to ventilate adequately or to provide sufficient oxygen to the blood system and organs. The pulmonary system is no longer able to meet the metabolic demands of the body with respect to oxygenation of the blood and or elimination of carbon dioxide. And you have, in the classification, you have type 1, which is called, that is the hypoxemia. And this one, you have the partial pressure of oxygen when it's measured using blood gas. I mean, it's less than 50 millimeters of mercury on room air, usually seen in patients with acute pulmonary edema or acute lung injury. Then type 2, you have hypercapnic or ventilatory failure. In this case, you have the partial pressure of carbon dioxide greater than 50 millimeters of mercury. The normal is up to 45. So if not in chronic, if it's not a chronic retainer of the CO2, so this is how you can diagnose type 2. So this is usually seen in patients with an increased work of breathing due to airflow obstruction or decrease. Cases that you have airflow obstruction, for example, if you have like in asthmatic, okay, or where you have, for example, you have those people that have upper airway obstruction from any cause. Then type 3 is perioperative, that is during surgery or after surgery. This is generally a subset of type 1, actually, type 1 failure, but it is sometimes considered separately because it is so common. And then you have the type 4, which is shock, due to shock, secondary to cardiovascular instability. The patient is in shock, it will be able to carry the oxygen to the system. Okay, so basically this is the reference you need to be able to classify respiratory failure. Let's go back to the main presentation. So the other question is that, okay, now that we know that we need to rely on the clinical signs, so can we list the clinical signs and symptoms of respiratory failure in adult patients? Let's give ourselves like 45 seconds. Signs and symptoms of respiratory failure in adult patients. And you can find all this classification on the Learning Resource Center. Anytime you log in, you can revise all this. So can we have some answers?
Okay, I think before we go further, it is important to note that for us to objectively say whether this patient has respiratory failure and to be able to classify the type of respiratory failure, we need an ABG, arterial blood gases. And the challenges with the ABG is that it's not available in most centers. And even in the centers where it is available, a lot of the times the consumables are not available. And even where they are available, some of the patients, the cost the patient cannot afford.
Yeah, that's correct. So in this case, you need to rely heavily on pulse oximetry, which we've seen earlier. You should revise all those areas that have been discussed in other previous sessions, please. Okay, so can we click now? No answer is coming. Let's see what we have here. Okay, so if we go, okay. Somebody now foreseen dyspnea. Cyanosis, okay. Okay, so I think there's a video here which we need to watch. There's no audio here.
Can you hear the sound?
No.
Okay.
Maybe we should try again. Okay. I don't know if Irene wants to take on this. Based on the video clip there, let's see if the participants are able to recognize some of these signs. Irene, are you around? Are you with us? Okay. So type into the box what you were able to observe in that short video clip in terms of the clinical signs.
Strike one.
Please, participants, mute your mics, please. Please mute your mics, please. Thank you. So some people said dyspnea, this patient was, yes, in respiratory distress. Dyspnea, there is use of accessory muscles of respiration, is tachypneic, and there's intercostal recession. Excellent. So these are the things you see on a patient. And if you go closely, you examine this patient, the patient might be cyanosed. And of course, you do your pulse oximetry, the saturation will be low. Okay, so like Dr. Salim said, we don't have facilities to run. We may have the money to buy the gadget or the equipment, but we won't be able to maintain. If you're able to supply the consumables and so on, then the patient won't be able to pay. So in the end, we won't be able to get what we want. So we'll have to rely on what we have, what is affordable to us, and make the best use of this pulse oximeter and pulse oximetry, which the previous sessions have dealt with, and you have a lot of references, a lot of charts that you can print out to help you out in managing your patients. Okay, so the practice change action here, we should be able to recognize when we should consult a senior doctor to help us decide on the next line of action, or even which may be to move this patient or to use a different device to achieve what we want, or move this patient to a unit in the hospital where the therapy can be escalated, or at best, if we don't have such facilities, you decide that we should transfer this patient to where this patient can get the therapy he needs. Now, we should also be able to utilize voluntary prone positioning in awake patients with hypoxemia who have escalating needs for supplemental oxygen. And we should be able to recognize a higher level of care, such as an ICU is needed when patients require 50% of FiO2. Salim has emphasized this, or 8 liters per minute oxygen therapy to maintain their SpO2 of 90 and above. Then we should be able to list the signs and symptoms of respiratory failure in adult patients. And we should recognize respiratory failure and call for help. So this is what we need to change in our practice to make it as simple as possible. Okay, so to review the topics here, we need to look at hospital admission criteria, which we've seen with this, the case discussed. Then COVID-19, we should be able to categorize this, the mild, moderate, and severe. This will help us on the type of intervention that we should start the patient on and when to escalate. And then the AIIR room and patient isolation strategies. Now we all agree that we don't have this room, it's quite expensive. So there are options to this AIIR room which we should adopt. And then we should learn about when to escalate the oxygen therapy, which we've discussed, and then how to escalate the care. You need to invite a senior doctor, you take decision, you need ICU or HDU, or you need to transfer this patient to a higher facility. Then you also, critical care outside an ICU can be done because where you have this high nasal flow oxygen cannula, you can use it. You don't have to do that in an ICU setting. Then the basis of reading chest X-ray, which we didn't really go into that, the science, classical science there, but the thing is that we should be able to read the findings on the X-ray, the chest X-ray. Then we've emphasized on awake prone positioning to improve recruitment of alveoli to improve oxygenation. Because with COVID-19, we know that there is de-recruitment. It starts in a vicious cycle and then patient continue to deteriorate, and finally succumb. And then we need to be able to identify when a patient is in respiratory failure. So broadly, these are the topics that we should keep reviewing in this session. Now you need to be going back to the previous session to understand all these other sessions because they are linked all together. And then some of them share the same materials and references. So to cap this, you should know that there is a quote here. The greatness of a community is most accurately measured by the compassionate actions of its members. So I think we've come to the end of this session. I would like to thank my colleagues, Dr. Salim from Bauchi, Dr. Irene, who is in Irua, Edo State in Nigeria, and then Dr. Suleiman from faraway Liberia, for participating in this great discussion. Your valuable contributions is highly appreciated. I want to thank also the participants for taking the time despite the Ramadan fasting for most of you to keep learning on this platform. Thank you very much.
Thank you, sir.
Thank you so much, Dr. Datti, for the session and all the panelists. We really appreciate. I'm sure me and all the participants, we have learned a lot from the session. So just to wrap up this session today, you can visit the Learning Resource Center, LRC, for the presentation, slides, and recordings. So this site also includes many additional resources, quizzes, case exercises, and videos. So that is the link. We will also be sharing this link in the WhatsApp groups as well, so everyone can have it. Links to the recording of this session in LRC will be shared after the session by email and via our WhatsApp group. For those of you who haven't joined our WhatsApp group yet, you can scan this QR code here, or you can message assist at this number written down here. So with that, I would like to thank you all for joining this session. Please remember to join session 5, which will be titled as a critical care outside the ICU, a rapid response, which will be held on May 27th. If you have any questions, please email to echo@assistinternational.org. Thank you all for joining, and see you next month.
Thank you.
Thank you.